Hi everyone, this is Heart Rhythm TV live from Atlanta HRX 2025. I'm Nashwa Abdulsalam, joined by Dr. Ashish Bhimani, Chief of Cardiac Electrophysiology at Piedmont Heart. Welcome.
Thank you very much for having me.
Well, we're going to start first by asking you to tell us about your background, your role at Piedmont Heart, specifically when it comes to cardiac device management and monitoring.
Absolutely. So I'm the Ashish Bhimani. I'm the Chief of EP at Piedmont. And so we're a big hospital system. We have 22 hospitals across the northern half of Georgia. And we, encompass over that, 3 or 4 flagship hospitals, but that includes about 14,000 patients that are being monitored on device through the Atlanta area, and then 24,000 if you include all our satellite hospitals as well. And so one of the questions is, how do we manage all that data? And so that's one of the things that I hope we can talk about a little bit today. But overseeing that is part of my process, as well as overseeing the rest of the Piedmont Heart EP group. So we have about 21 EP doctors, includes another 13 device technicians, and across all those hospital areas as well.
Yeah, cardiac device monitoring, has always been a challenge. And so my question for you as the Chief of EP, what are the obstacles that you and your team encounter with that, and how do you manage it?
So it's interesting, as the group has grown, when there were small silos, there'd be, an EP physician, a device technician, and, maybe an APP to help out. And that volume would continue to grow. But then as devices have become more complicated, patients have a number of issues that happen in between clinic visits. The need for remote monitoring is clear and evident. And so being able to manage that volume has become a bigger challenge. Then as the group has grown, we've obviously increased the volume of patients, but increased the volume of providers, and then figured out some way to triage and make that workflow efficient has been one of the things we've had to work with. The device technicians, if we needed a device technician to cover every situation, to monitor all these devices, make sure the patients are set up, look through each of the different vendors' platforms, it would just be impractical to hire enough device technicians ourselves to manage that. And so we realized that we needed help. And so that's really what was the impetus for us to get into a third-party solution, and Pacemate would sort of provide that for us. But how do we manage that large volume of devices, remote monitors, and then get the patients enrolled, see those alerts, get them triaged appropriately, and then navigate them to the right physician, to the right nurse, the right APP in a way that we can then clinically act on it, because we're talking about a wide geography as well as a wide number of providers.
And so can you get more into the details of how Pacemate has helped you with that?
Yeah, absolutely. So, in the past, to paint a story for how it was prior to Pacemate, we had 2 of our device technicians that worked on the remote side. And so they would try to get all the remote data from, each of the vendors' remote clouds. They would get all that data, so, all morning long, they would just go one vendor site to the next vendor site, collect all the data, and then they would have to go through each of those patients, pull up the EMR, find out if they were on a blood thinner, if they had a new episode of AFib, or find out, what antiarrhythmic drugs they were taking. Then they would go through that list and start sending those information to the nurse, to give over to the physician. But that was just, the volume was becoming too high. And so we actually ended up not having a lot of our patients on remote. We asked them to come in because there was no way that we could triage them appropriately through the remote monitor. So the ones who weren't being remote monitored because they got disconnected or fell off, we didn't spend any time or effort trying to get them back on because we couldn't handle that volume. Now we have, someone else that's sort of doing that first step. What are the meds they're on? What device do they have? What alerts came through? And then also triaging it so we, the actionable ones, the important ones we see first. And then we get through the ones that are a little less critical. But having somebody to, get the initial alert, figure out the distribution, has really offloaded our device technicians. So now that we can work on the, the clinical action that needs to take place. And so they can much more readily go to, okay, well, this is what's going on. Let's get them in for a change out. Let's get them in for discussion with a doctor. Let's get them in for medication changes, et cetera.
Oh, interesting. What about your VT treatment center, and how did Pacemate data analytics help you with that?
Yeah, so the VT Treatment Center is a great tool that we've been able to partner with Pacemate on developing. One of my partners, Dr. He's one of our VT ablation specialists. And, again, with a broad geography and broad set of skills amongst our EP docs, a lot of times when you get into a silo, you're sort of, thinking about what you can provide for the patient. And sometimes you step away from thinking about the whole system holistically. We have a lot of patients who have, an episode of VT, maybe a second episode of VT. They get treated with antiarrhythmic drugs, and we just continue to watch them. But when you have, specialist hands that do, more complex VT ablation procedures, it's important to sort of keep that in mind is, okay, this is an option for them. And so on the one hand, you could ask every provider to be like, okay, keep it in mind that, we know we have this availability. Obviously for the doctors at Atlanta or, that work with Dr. Krivenpour, we see that all the time. But when you start thinking about the general cardiologist in a smaller satellite facility, they may not be readily remembering that, okay, they've had 3 VT episodes, we should get them in. And so Pacemate was able to pull all the data for the patients we have with devices from Epic. So now we can combine their ICD data with their clinical data. So when were they hospitalized? How often have they been having VT? Is it ischemic or non-ischemic? What antiarrhythmic drugs are they on? And so now with a single platform, we're able to see, which patients might be amenable to VT ablation. Where do we need to step up our drug monitoring to make sure that we're not missing, drug toxicity interactions? And then also to help guide, okay, well, these people have had ablations. What are the successes? How well are they doing? Epic has a lot of this data, but the reality is it's very difficult to change Epic in a way that can get the data you want in a dashboard that works for you. And so that's a, many steps, often many years process to do. Whereas Pacemate had a lot more flexibility to pull the data and then create a user interface that was much more usable for us. And so we use that routinely to help manage our patients with VT, which is a large number of patients, and we sort of separate them out into tiers. So those that have been complex VT ablation with a number of shocks versus those that are just at a higher risk and maybe had some VT episodes with only 1 or 2 therapies.
Okay. That's really, really wonderful and insightful because, as we were discussing yesterday at one of the sessions, how remote monitoring is such a burden, and just hearing your experience and, learning from that is really, really helpful to others in our audience, especially, with the VT treatment program, like it's taking it a step further on using that data also and take it a step further for managing patients. So thank you for that.
Absolutely. Yeah, so one of the other things that we, think about, how do we take this data now that we have this big pool of data and help improve the way we manage the patient? And so the other thing, maybe on a more simplistic side, rather than the complex VT patients, is we have the patients, we see, what alerts come through. And so, for example, patients with pacemakers often will have, a short run of non-sustained VT. And clinically, it's not really clear, when to act on that and when it's meaningful. And so one of the questions is, how do we monitor that? How do we act on that? And then the nice thing about having a vendor agnostic platform like Pacemate is that we can then compare, how things are set up in each of the different vendors' implants. And so we were able to look at that and say, okay, well, this particular vendor has a much higher frequency of alerts for this problem. Maybe we need to change the criteria or adjust the criteria. And we do that on a regular basis. So we meet with the Pacemate team, see how the the different alert criteria are set for the vendors at the vendor cloud sites, and then through Pacemate to try to help homogenize that, figure out where the alert burden is, and try to bring that back down in line with what actionable items are. So the people who have longer non-sustained VT or have other risk factors, those are the ones who might want to be doing more cardiac testing, antiarrhythmic drugs, etc.
Well, thank you for sharing this experience. That was very helpful and insightful. And to all our audience, continue following us for more content of HRX 2025.
Thank you so much for having me.